It's 2 a.m., your pager goes off. Hey doc, patient room 404, heart rate is 34. What's the first thing you do? If your answer is call for atropine, you may already be making mistake number 1. Here are the 5 mistakes I still see residents make. Mistake number 1, treating the heart rate before assessing the patients. A heart rate of 34 gets everyone's attention, I get it. But that number alone tells you nothing. The first question is this patient actually sick? When I get this page, here is exactly what I say to the nurse. Please get a full set of vital signs and a stat 12 lead EKG. Is the patient symptomatic? Put them on telemetry if they are not already. I am coming to assess right now. Those tips happen in parallel, right? Confirm the current vitals, get the EKG and read it. Check mental status. Are they confused? Are they perfusing? Pull up the telemetry trend and determine the rhythm. Is this a sinus bradycardia, AV block, pauses, or is this an artifact? Here is the comparison that matters. A sleeping patient with sinus bradycardia at 34, normal blood pressure, no symptoms. That's a very different patient from someone with a heart rate of 42, hypotensive, chest pain, and altered mental status. Heart rate of 42 here is higher, but the patient is sicker. So do not treat the monitor, treat the patient. And one more thing, asymptomatic does not always mean benign. A very low or falling heart rate still needs reassessment, rhythm confirmation, and preparation to escalate if things change. The rule here, at 2 a.m., the safest first move is not automatically atropine. It is deciding what kind of bradycardia you're actually dealing with. Remember that. Mistake number 2, repeating atropine when pacing is the right next move or step. Now let's talk about atropine, because this is where I see a real delay. Atropine is your first line medication for symptomatic bradycardia. Yes, but in this matter, it is not equally effective in every rhythm. Atropine works by blocking vagal tone at the AV node. It works well for sinus bradycardia and AV nodal blocks. The dose 1 mg IV, repeat every 3 to 5 minutes, up to 3 mg total. But here is the problem. If the block is below the AV node, like Mobitz type 2 second degree AV block, complete heart block, atropine is unlikely to help, and it can actually worsen conductions. Right. The mistake is not giving atropine here. The mistake is giving repeated doses while the patient is sitting there unstable, and you are delaying the thing that will actually help. Pacing. For unstable patients, move to transcutaneous pacing. Place pacing pads immediately. Don't wait. Give atropine, assess the response. I'm okay with that. And move on quickly if it doesn't work. Transcutaneous pacing is fast. Yes, it's uncomfortable. Explain what's happening. Provide analgesia and sedation when feasible, but do not delay pacing for a crashing patient. And do not forget that you can use epinephrine or dopamine drips. They can be used in hypotensive bradycardic patients, especially if the patient refuses pacing or pacing is ineffective. And please call cardiology early. Transcutaneous pacing is a bridge, not permanent solution. The patient may need transvenous pacing. The rule here, do not let atropine become a delay. Mistake number 3, treating every medication related bradycardia the same way. Patient becomes bradycardic, nurse asks, do you want me to hold that metoprolol? Simple question, but not a simple straightforward answer. The answer depends on the rhythm, the hemodynamics, and the trend, and how important the medication actually is for this patient. Here is the framework I use. Continue the medication when the bradycardia is mild, brief, asymptomatic, and the medication has a clear indication. For example, a patient on metoprolol after NSTEMI whose heart rate briefly dipped to 48 during sleep with stable blood pressure and no symptoms, you do not need to hold it. Or reduce the dose when the bradycardia is recurrent or persistent, typically below 50, but the medication is still needed. Let's, for example, patient with HFrEF on carvedilol 6.25 mg BID, for example, whose heart rate keeps running below 50 on telemetry, we consider cutting the dose, not stopping it. Third, hold or suspend the medication when the bradycardia is symptomatic, associated with hypotension, worsening, or there is a high-grade AV block. For example, a patient on metoprolol or amiodarone who develops complete heart block. Hold both reassess after the cause is clarified and treated. And fourth, discontinue or replace the medication when there is no compelling indication, toxicity is suspected, or significant bradycardia continued despite dose reduction. For example, a patient who is on Precedex drip in the ICU with mild bradycardia with preserved perfusion, we may reduce the dose a bit, but if the rate keeps falling or the patient becomes hypotensive or pauses or high-grade AV block, we discontinue that immediately and switch sedation strategies. The rule here, mild sinus bradycardia, symptomatic bradycardia, and high-grade AV blocks are not the same problems. Don't treat them the same way. Mistake number 4, treating sleep bradycardia as pathologic. Classic 2 AM page. Oh, the patient's heart rate dropped to 34 while sleeping. What do you do here? Here is something most don't know. Bradycardia during sleep is common and usually physiologic because the parasympathetic tone is dominant during rest and sleep. Sinus bradycardia below 40, even pauses greater than 5 seconds. These have been observed in healthy individuals. Normal physiologic, benign, a brief episode of sinus bradycardia that resolved when the patient wakes with stable blood pressure and no symptoms. That usually does not need atropine, pacing, or a medication hold. On the other hand, do not dismiss every low heart rate as just sleep. That is the other extreme, and that's how you miss something dangerous. Review the telemetry strip and ask the following. Is this sinus bradycardia? Does the rate improve when the patient wakes? Is this episode brief or sustained? Is there high-grade AV block? And one more thing. Recurrent nocturnal bradycardia may be a clue to sleep apnea. Ask about it, screen for it. But nocturnal bradycardia alone is not an indication for a pacemaker or medication hold. The rule here, the mistake is either extreme, treating every sleeping heart rate in the 30s or dismissing a dangerous rhythm because the patient happened to be asleep. Let's move to the final mistake, mistake number 5, poorly handled pauses on telemetry. So this comes up constantly overnight. The patient had a 3.5 seconds pause. What do you do here? Please, before you do anything else, get an EKG. Remember, don't get tired of getting EKGs and review the actual telemetry strip. Artifacts, blocked premature atrial contraction, and telemetry disconnections can all be reported as a pause. The 3.5 seconds pause may not even be real. If you confirm it real, then ask, was the patient awake or asleep? Was it symptomatic, isolated or recurrent? Was it sinus, a pause, or AV block? Are rate slowing medications contributing? A brief, isolated, asymptomatic pause during sleep that may not require treatment, but a pause that's recurrent, prolonged, occurs while awake, causes dizziness, syncope, or hypotension, or represent high-grade AV block, that's a very different situation entirely. Some people uses a 3-second rule as the threshold for further investigation, but there is no established minimum pause duration where pacing or treatment is automatically recommended. The clinical context drives the decision. For concerning prolonged and symptomatic pauses, place pacing pads if deterioration is possible, halt contributing medications, correct reversible causes, escalate monitoring to ICU or step down, and loops in cardiology early. When in doubt, loop in the next level early. That is not overreacting. That's a good medicine. In the end, half of these 2 AM bradycardia pages can be handled with confidence if you use the right framework. Remember, we always say stabilize, recognize, and then treat. Do not react to the monitor number. React to the patient in front of you in all situations, not just bradycardia. That's how you go from reactive to confident. And please subscribe if you haven't already. Thanks for watching. And if you would like to receive a written summary of this video and access previous videos summaries, you can subscribe, or you may get that by subscribing to my Substack. The link is provided in the description field. Thanks for watching again, and I'll see you at 2 AM.